Hello, and welcome to our online training, Communicating Effectively with Patients. My name is Marcia Gelt, and I'm a Program Director for CARDIA. On behalf of the California Primary Care Association and CARDIA, we are pleased that you have selected this module to support your professional development. CARDIA is a nonprofit, mission-driven organization with a principled team of committed and passionate staff who have dedicated our careers to helping health and human service providers offer their best to their patients. You may be aware that CPCA is offering this training as part of their Patient-Centered Health Home Recognition Program. This initiative is for its member clinics to support their efforts to achieve Level 3 standards of National Committee for Quality Assurance Recognition. Before we begin, I want to encourage you to download the associated handouts on CPCA's website. I'd also like to quickly review some instructions for this session. I will be using the terms healthcare provider and healthcare staff interchangeably and will sometimes use the term counseling as it applies to a patient interview or interviewing skills. Also, throughout this session, I will cue you when it's appropriate to stop the recording to complete an activity or to use a handout. By the end of this session, participants will be able to describe the patient-centered interviewing approach, explain how to establish trust and rapport with patients, and demonstrate the essential communication skills every staff member should be able to use to conduct a quality patient interview. So I'd like to start by making a case for why healthcare providers might want to use an interactive approach to communicate with patients. After all, talking to patients in the limited time you have just means giving them the information they need to know, right? Well, actually, your professional role is to establish a safe environment, a climate of caring, respect, acceptance, and understanding. In a safe environment, you as a professional can facilitate a process to help a patient loosen his or her defenses and explore options to make more effective decisions. Why are we placing such an emphasis on good communication? I'm sure that many of you feel that you already do all the communication you can in the short time you have with each patient. What more can you do? And it isn't so difficult, is it? Well, in fact, 83% of physicians believe that communication is as important as technical skills in patient outcomes, but only 18% believe they have had good training in patient communication. Physician communication, or the lack of it, is probably one of the most important factors for patient noncompliance, and the most important determinant of clinician global satisfaction is the clinician-patient relationship. And there is a lot of evidence that shows that the most common cause of malpractice suits is failed communication with the patients and their families. June Fabre, author of Smart Nursing, How to Create a Positive Work Environment that Empowers and Retains Nurses, said it is very important to stress how important nurse communication is to patient safety. Fabre pointed to the Joint Commission's 2008 National Patient Safety Goals, which list improve the effectiveness of communication among caregivers as the second goal. She said that according to the Joint Commission, poor communication is the #1 cause of serious medical errors. There are more reasons to master good communication. It results in more efficient data gathering, better patient outcomes, better patient compliance, improved patient satisfaction, decreased malpractice risk, and improved physician satisfaction. So I'm going to suggest today that patient-centered interviewing is the best approach to communicating with patients. So what is being patient-centered? It is a dialogue between the healthcare provider and the patient. This concept is based on Carl Rogers' theories of counseling and was adapted by the CDC in 1993 in response to the AIDS epidemic. CDC's working definition states that patient-centered counseling is counseling that is conducted in an interactive manner through the use of open-ended questions and active listening, which focuses on developing prevention objectives and strategies with the client rather than simply providing information. Patient-centered counseling is making information useful by helping the patient figure out how to integrate your information into their personal life. It's important to recognize the patient's capability to make their own decisions. If the healthcare provider makes decisions for the patient, then the patient becomes totally reliant on the healthcare provider. This means that we do more interviewing using counseling skills rather than information giving or education. So what is information giving versus interviewing? We think that education is telling our patients all the information they need to know. We need to redefine this concept. Interviewing is a dialogue, meaning that it's two-way communication. It's individualized to that particular patient, taking their feelings and beliefs into account, and it helps the patient understand themselves better. And it also can be short and tailored. Whereas information giving is one way, usually with us doing all the talking and the patient doing all the listening, it's not tailored to the individual. It sticks to the facts about that particular topic to help a patient understand a subject better rather than themselves, and it can also be short and tailored. Interviewing is the process of sharing information and experiences to help people discover and use new knowledge in their lives. It involves personal trust and two-way communication. It's not advising, mothering, or solving our patients' problems. Providing information is not enough to get people to take a health-related action. For example, smoking. Everybody knows that smoking is bad for their health, but there are people that are still smoking. Obviously, they know this information, but they have not stopped smoking. The goal is to enable people to make informed decisions and act on them. Often I hear that healthcare providers are reluctant to do patient-centered interviewing because they think that it will just add time to the visit. So to make my case that it may actually save time, let me move forward and delineate the principles of patient-centered interviewing. Number 1, don't make assumptions. Don't make assumptions about what patients know. Find out what they already know. For example, if a woman comes in for the birth control pill, don't assume she's never used it before. Maybe she has, but is just now coming to your practice. Spending time telling her all about the pill is a waste of time. Ask her what she knows, and if she hasn't used it, you can bet she's heard about it with all the ads on TV. She knows something, and whatever it is, build on that. You don't need to go into a lot of detail with her. There are a lot of people out there that may just need a minor correction or update because they've learned about it on Google, and that alone can save time. Number 2, assess and improve their perception of risk. Find out what patients perceive to be their risk and build on that. If they think they'll never catch the flu, for example, because they haven't caught it for the last 5 years, but you know that their community has been particularly infectious, give them that information so that they can make a more informed choice about whether or not to get the immunization. Number 3, ask open-ended questions in order to find out what they know and what particular concerns they have. Get the patient to talk with you. We'll spend a lot more time on this later. Number 4, tailor the session to address patient concerns. The patient's agenda takes the main stage. You can have an agenda or a computer with an agenda and still be patient-centered. Being interactive means that a conversation takes place, not a lecture. Number 5, use the same words. Try to use the language that the patient uses to make it more comfortable. Do not use language that makes you feel uncomfortable because the patient will pick up on that or you'll seem phony. Sometimes patients are unsure about how to express themselves, and it can really help to use permission-giving statements. If you ask a patient what brings them to the clinic and the answer is, "I'm not sure how to explain it," you can respond by saying, "Just say it in your own words," or "Say it however you want to." Number 6, talk less. A good patient-centered interview means that the patient will be doing 50% or more of the talking. Of course, that's difficult for some of us who like to talk, but it's really important that they're engaging with you in conversation. Additionally, I have to say that there are times where you will be doing more information giving, and you will be doing most of the talking. But this is sort of a guideline for the general interview, that they are engaging with you and talking at least 50% of the time. To create a place that patients will be more willing to talk openly, we need to maintain a non-judgmental stance, especially when talking about personal health behaviors. Telling a patient that they are obese with judgment will not increase the chances that they will adapt new healthy behaviors, that's for sure. A key factor for maintaining a neutral stance is being aware of our own biases. This does not mean that we condone all behaviors. We each have our own values and beliefs, which we are 100% entitled to. But our job as professionals is to keep them out of the way when we're with patients. Being non-judgmental means that we are willing to listen and discuss the patient's true concerns without interference from our own biases. So how can we recognize a bias? Anything that pushes our buttons is a bias. Anytime we begin to feel emotional or hot under the collar, that's when we know to stop and figure out how to go on without bias. We also need to address emotions directly, to identify and validate emotions of the patient so that they feel heard and can process information that you want to give them. If you ignore emotions, they can serve as an obstacle to communication, another concept we will discuss further in a bit. Number 9, support positive changes. Whether patients are thinking about making changes or have already started to make changes, or they're barely thinking about it, we need to give positive feedback about what patients are doing to improve their health. Offer options, not directives. It can be hard to accept that the patient is in charge of his or her behavior. We aren't responsible for making choices or decisions for patients. Of course, this has to be done appropriately. We're not going to offer patients a variety of medications and let them choose if they have a bacterial infection. We will be more directive at times. But when we can, we should offer a variety of solutions so that they can decide what to do. They are the ones who are going to have to do it after all. So the key points to remember in patient-centered interviewing are: number 1, to have a belief in your patient to be able to solve their own problems; to number 2, create a safe environment for your patient; and at number 3, the professional qualities that are essential and sufficient to work with patients are to be genuine, demonstrate empathy, and to have an unconditional positive regard for your patient. Incorporating all of these principles into your communication with patients will greatly enhance your relationships with your patients without taking a long time. In fact, a single session of patient-centered counseling has also been shown to be effective in changing health-related behaviors even when the counseling duration is 15 minutes or less. Of course, there will be those patients who need more time or those who tend to talk off topic and need to be gracefully interrupted, but this approach can be used the majority of the time. So let's move on to talk about the foundation of patient-centered interactions. Many people feel powerless and angry with doctors and hospitals because they feel they have not been listened to in the past. Dr. C. Everett Koop, former Surgeon General of the U.S., says that patients' number 1 concern is that my doctor is not the kind of man or woman I would want the doctor to be. She or he doesn't listen to me, or when I talk to him or her, she or he doesn't understand me. So the first step in effective two-way communication is establishing trust and building rapport to help patients feel comfortable with you. Research has shown that in general, people have 30 seconds to 2 minutes to establish rapport. Think about how people try to establish rapport in different situations. For example, when you go to see your own physician, does the receptionist greet you with warmth? Does the medical assistant call you with a smile and seat you in the exam room with an explanation of what will happen next? Does the physician greet you and ask how you are? These attempts to build rapport can go a long way in any personal or professional situation. This may take only a minute or two, or it may take a little longer, but the payoff is the chance for your patient to warm up to you, and it gives you insight into who they are. This body language and tone checklist offers some things to consider. When you speak with the patient, is there a desk between you and the patient? Someone sitting behind a desk is a well-known position of power and authority. If there is any way to position yourself so that you're sitting at the side of your desk with your notes or your computer at the side as well, it will allow for a more conversational feel to the interview. Think about your posture. Are your arms crossed in front of you? This is actually a position that I sit in often if I'm cold, but it can present as uninterested or even hostile. Some people have a habit of quickly shaking or moving their foot. This is just a nervous habit, but it can come across as impatient or bored. Are you looking at your patient, or are you looking at your computer or your notes? It's very easy to get into the habit of just looking at the electronic medical record system you may have in order to get all of your questions answered, but it can take away from your interaction with your patient. And if your voice does not indicate interest while you're asking those questions, then the patient can easily feel discounted and may not give you all the information you need. The rest of the tips on the slide speak for themselves. It's just in order to remember that we all want to be treated with respect and interest when we're disclosing personal information to our own healthcare provider and hoping to receive personal caring treatment. During the patient's visit, a couple of other things you might want to do are, of course, to introduce yourself. In just 1 or 2 sentences, say what you do and what the time frame is that you have with that patient. Ask the patient how she or he wants to be addressed. This helps the patient to feel respected by you. If they have to wait, give them a general time frame. This acknowledges that their time is important too. We all know what it's like to wait for a doctor's appointment and how helpful it is to know what the wait time might be. Set the agenda. You could say, I know we have only 10 minutes today. I want to hear about what's going on with you and your child. I also need to get some information from you before I go. A key component of establishing and building rapport is, of course, body language. Language includes more than the mere words people say and write. In many ways, the words we say are inconsequential in comparison to how our bodies communicate. An amazing 65 to 90% of all information communicated is carried by the body. Things like the tone of voice, the posture taken, and the look in your eyes are all part of the message received. Anything a person does that transmits information, including gestures, facial expressions, body posture, intonation of your voice, and rhythm of speech, is language. It's important to remember that body language can be misinterpreted. You may have seen patients who seemed to be very calm but were actually quite angry and disturbed. There have also been other situations where patients who seemed very angry and upset were just very nervous. When in doubt, always ask the patient how they are feeling at that moment to avoid a misunderstanding. Patients also communicate with us with their body language, and we can misinterpret them as well. In a classic 1993 study published in the Annals of Internal Medicine, the tremendous power of body language was demonstrated with real-life medical problems. The study divided internal medicine specialists into 3 groups. The first group was shown the written dialogue of a 40-year-old woman referred by her gynecologist for evaluation of chest pain. The second group of doctors saw a video of a professional actress saying the exact same words. The actress was dressed flamboyantly, spoke in a shrill voice, and acted upset. The third group of doctors saw a video of the identical dialogue. However, this time the same actress was dressed nicely, spoke softly, and was described as elegant, conservative, and businesslike. Can you guess what happened? The first group of doctors who saw only the written dialogue was split on whether they would perform a diagnostic workup. The second group of doctors chose not to pursue a diagnostic workup in the emotional patient. The third group of doctors was nearly unanimous in their decision to give the business-like patient a complete diagnostic workup, fearing that she was having a heart attack. Remember, the words were identical, yet the outcome and treatment were totally different. In the real world, the patient's body language could have made the difference between life and death. So the study was an illustration of how we can misinterpret our patient's body language, but it is also important to consider verbal and nonverbal cues that you give and receive. Body language and eye contact are very important cues to the patient. Your body language and tone tells your patient when you are paying attention, even though you may not be saying anything with words. But the primary technique of patient-centered communication is active listening, which is a specific communication skill based on the work of psychologist Carl Rogers, which involves giving free and undivided attention to the speaker and tells the other that we are interested and concerned. It is also defined as placing all of one's attention and awareness at the disposal of another person, listening with interest and appreciating without interrupting. Active listening is the primary technique that fosters understanding between the healthcare provider and the patient. It is unusual to be given the opportunity to follow through a train of thought without interruption. In fact, I often conduct a simple activity when I lead workshops on communication skills. This activity involves asking pairs of participants to take turns speaking about themselves for 60 seconds. The listener must not speak and can only communicate with the speaker with their body language to demonstrate that they are listening. What often happens is that the speaker can feel uncomfortable speaking without any response or interruption for just 1 minute, and the listener feels uneasy not talking. When I discuss the activity with everyone, participants acknowledge how our culture has become so fast-paced that it's a shame that we cannot listen to someone's story for just 60 seconds without interrupting. In fact, think about in your own life how rare that is, to be listened to for such a short time. And I encourage the listeners who feel uncomfortable not responding for 60 seconds to think about how you can show someone that you are listening without talking. When a listener does not introduce their own views or solutions, they are far from passive. Instead, they draw on high-level skills in assisting the speaker to reflect. Under the circumstances, what is amazing is not that communication so often breaks down, but that it works as well as it does. So let's apply the concepts of active listening to clinical practice. Misunderstanding and being misunderstood are part of everyone's daily experience. However, most doctors and patients remain unaware of the frequency and extent of miscommunication in medical settings. It's often because of this miscommunication that patients often feel that, quote, "my doctor didn't tell me anything." While social miscommunications can result in hurt feelings, missed engagements, and other complications, medical miscommunication can have dire consequences. It's important to recognize that language used in healthcare is not ordinary language, and the problems it can create are not ordinary problems. That is why patient-provider communication requires special attention. Ian McWhinney, a well-respected physician from Australia, asserts that the greatest single problem in clinical interviewing is the failure to let the patient tell their story. Active listening is an advanced communication skill which takes practice and constant awareness. It is not a skill that can or should be used all the time, for example, in a medical emergency or when the patient is drug affected. To empty oneself of one's own prejudices, patterns of responding, and frame of reference, and to try to understand all of this about another person is an act of great generosity and respect. But the core of effective communication has more to do with how we listen than how we speak. It is the age-old skill of active listening. Dr. McWhinney was interviewed in an article entitled "Listening to Patients, A Lifetime Perspective" from Ian McWhinney in 1998. He said, "You can learn to be a better listener, but learning is not like learning a skill that is added to what we know. It is a peeling away of things that interfere with listening, our preoccupations, our fear of how we might respond to what we hear." Many things can get in the way of good listening. Here is a list of behaviors which can interfere with active listening. Daydreaming, meaning that your thoughts are wandering. Even if it's not a fantasy, it can be just that second voice in our heads, like planning dinner or what we're going to do after work. It's just like right now, you aren't listening to everything I say. Labeling, meaning categorizing the person before listening to them. We all do this, and it's certainly typical human behavior. We just have to be more aware of it when communicating with patients to not let it get in the way of what the patient might be saying. For example, I have a female coworker who works with adolescents and started being very afraid of large male youth, especially those dressed in what she thought was close to being gang attire. When she got to know these young men, she realized that prejudging them really got in the way of forming relationships. Almost all of the men she works with are helpful, respectful, and caring youth. Relating everything you hear to your own experience, which is easy to do, but we can never be in someone else's shoes. And even if we have this very same health issue, how we deal with it can be so different from another person's management style. Mind reading, predicting what the other person is going to say. Rehearsing, practicing your lines in your head while the other person is speaking. Selective listening, listening only for what you want to hear, then switching off. And interrupting, cutting the speaker off with questions, comments, or unsolicited advice. And finally, avoiding feelings, countering expressions of emotions with jokes or cliches. This usually happens when we feel uncomfortable with someone's feelings. A sign that communication is not working can be when the patient starts to block your suggestions. This can be frustrating to both parties and distract you from teasing out all the thoughts and emotions about the problem. Alternatively, some people simply shut down, outwardly appearing passive and compliant, but inwardly disengaged and resigned to not getting the help they really need. These roadblocks deny the person the opportunity to talk about their problems, or worse still, try to convince them that they really aren't serious problems and that they are foolish to be worried about them. So 3 things can happen when you fail to listen or pay attention. You'll hear what you want to hear, you'll hear what you expect to hear, and you will not recognize the difference between a statement, an objection, and a question. People speak at 120 to 180 words per minute. People think or hear at about 400 words per minute. So what happens with the time in between? If we're listening to someone who speaks more slowly than we can hear, we're filling in their gaps, finishing their sentences in our head. This is a signal that we need to slow down and really listen to our patient. I'm going to move on now to the interviewing skills, ORS. This is a model that has skills that anyone who does interviewing, from a medical assistant to a counselor to a nurse to a doctor, needs to use. Open-ended questions cannot be answered with a yes or no. They require elaboration. These questions encourage the patient to talk about their experiences and invite specifics. They help to understand the patient's perspective and motivation. They also help to set the agenda for your time with them and to elicit change talk, talk that indicates they are willing to make a change about their behavior. They are typically very general and help you to get a broad sense of what's going on with them. Most people learned in school that open-ended questions start with who, what, when, where, or how. They help to get people to open up, to encourage more conversation, and gives the patient some degree of control over what they want to share with you. Using questions like, "What brings you in today?" are extremely useful to solicit the patient's concerns and agenda. They can actually make your job easier by eliciting information without having to ask a lot of additional questions. The ability to ask open-ended questions is probably the most important tool in doing effective interviewing. This is the big time saver. According to researchers, the use of open-ended questions and active listening during the patient's opening statement added only 6 seconds to the average visit length. In exchange, according to researchers, patients are more satisfied, adherent, and report better outcomes. Some examples of good open-ended questions are: what are your thoughts about? What kinds of thoughts have you had? How did you feel when? Or tell me more about, which is a great question you can use in any situation. One caveat though, avoid using why. Questions starting with why generally put people on the defensive, as they are being asked to explain their own behavior, which can be difficult for anyone to do at a given time. Humans don't always know why they do something. Also, the question, "Can you tell me more about?" is not actually an open-ended question. It allows the patient to say, "No, I don't want to tell you more about whatever it is," and then you are at a dead end. In fact, it is recommended to open the conversation by explaining that you will indeed be asking questions about personal information in order to give the patient the best health care you can. Here are some health-related, open-ended questions. As you can see, none of them can be answered with a simple yes or no. Here are a couple of examples of how to convert closed-ended questions to open-ended questions. Do you think you'll need help after your son's surgery? Converts to, what kind of help do you think you'll need after your son's surgery? Is everything okay with the baby? Converts to, what's happened with the baby since our last visit? This is harder than it looks, but it can be so helpful to use open-ended questions so that patients don't feel like they are being battered with one question after another. If you have an electronic health record system that does not allow you to ask, you may want to review the questions there and see if you can use one or two good open-ended questions to get the answers to most of those closed-ended questions. It's also surprising the power of simple acknowledgement in itself. If a person's concerns and worries are not addressed, they tend to compound over time. Affirmations show an appreciation of the patient's attributes, their effort, their perseverance to show up to see you that day. All patients need confidence, self-efficacy. You can support their self-efficacy by recognizing their personal strengths, resources, and successes. The praise that you give them must be personal and genuine. For example, there are some groups of patients that may receive little praise, such as adolescents who rarely hear anything good in their daily life. You may be that person to praise them and make them feel good about themselves. For an example, you could say something like, "It's great to see you here today, especially with all you have going on." This can relax the patient and diffuse some hostility they may have coming in. The third letter in the ORS model is R, which stands for reflective listening, defined as the effortful use of listening to seek, clarify, and deepen understanding, which creates awareness of gaps in understanding between you and your patient. The first part of reflecting that I'll discuss today is paraphrasing. This is not just repeating back what someone says. The purpose of paraphrasing is to restate briefly what the patient has said in order to show that you understand. It is not parroting back verbatim. Rather, it is using your own words to capture the essence of what the person is saying. It also reassures the patient that you are actively listening. This gives the patient a chance to clarify or correct what you think they have said. An example of paraphrasing would be if the patient says, "I'm really in a hurry about this exam and I don't understand what is so important about it. After all, I don't know why you need one." And you might say, "I can see that you're rushed and don't know why you need the exam." Notice that the provider did not immediately go into providing information about the exam. Rather, they paraphrased what the patient said to be sure they understood. In the second example, the patient says, "I don't think I can go back to work. My baby needs special attention." And you might say, "It sounds like you can't think about work while your baby is sick." The purpose of reflecting feelings is to let the patient know that you acknowledge and understand their feeling about a situation. By acknowledging their feelings, you can help them feel less alone and more understood. Generally, you will get cues from the patient about what they are feeling, but if you're uncertain, the best way to know is to ask. Asking is not prying, and ignoring the feeling can give the impression that you're not paying attention or that intense feelings scare you away. Ways to do this include, "It seems to me you are feeling blank because blank," or "It sounds like you are feeling whatever." If the patient corrects you about the feeling you've identified, graciously accept the correction and acknowledge your new understanding. An example of reflecting feelings would be if the patient says, "I've never been here before. Am I going to get some kind of exam?" And you might say, "It seems to me you are feeling a bit anxious about the exam." Notice how the provider again did not go directly into information giving, but just reflected the feeling. Here's an example of reflecting feelings with a correction. The provider says, "I notice that you're quiet now. It may be really hard to talk about this. What you've been telling me can be really scary, and I wonder if you're feeling that way." And the patient says, "No, I'm just really angry." And the provider reflects, "I can see how that would make you mad, not scared. Thank you for telling me how you really feel." Here's an example of talking with a patient who is struggling with smoking. Take a minute to read the slide and think about what possible responses could reflect this patient's feelings without going right into giving information. Pause the recording and write a couple of different responses down. Here are some possible responses. Check to see if any of yours were similar. Although this can sound trite or superficial with these examples in this setting, we all know what it's like to have someone ignore our feelings and just try to fix the problem. It can be very invalidating and feel dismissive. How many people have been to a medical appointment and at the end get dressed and are sitting in the exam room a long time and no one tells them that the visit is over? You may wait and eventually get up and ask someone what's going on. This illustrates what's important and helpful about summarizing. Without it, patients may not know where they are or are not in their visit. Summarizing's purpose is to establish a mutual understanding of the concluding agreements. It affirms what the patient has said and shows that you've understood the whole message from them. Some summarizing questions to ensure that you have the whole idea of what needs to be summarized include, do you know what to do next? What will you do first? Is there anything we haven't covered? Then you would need to think about all of the things the patient has said, link them together, and state the overall message, including all of the relevant parts. An example of summarizing is, "So it sounds like your son is getting too heavy for you to lift and that you would like to discuss durable medical equipment options with his physical therapist." As you can see, summarizing is helpful not just at the end of a visit, but along the way. In summary, these skills will ultimately save time in the session, as you will be hearing more information from the patient earlier in the visit and avoid asking many unnecessary questions. This slide summarizes all of the skills and tips thus far as guidelines for practice. I'm now going to discuss some other factors that can influence communication. Research shows that men and women communicate in different ways, which can lead to much frustration and puzzlement, as many of us can probably relate to just from our personal lives. But recognizing these differences and incorporating some knowledge about them can improve our relationships with patients. There are differences in men's and women's experiences, but in reality there is more in common than there are differences, and it's important to not make assumptions based on gender. Every individual is unique and brings their own set of characteristics, attitudes, and expectations to the situation. I do not intend to make comments to stereotype, rather to help aid in how we might improve our communication in some situations, the interview. The characteristics presented about any group based on age, gender, race, ethnicity, sexual orientation, socioeconomic class, etc., is true for some but never for all members of a group. So this discussion provides a framework for considering communication approaches with women and men. However, there are factors that influences men's approach to healthcare that I'll spend just a few minutes talking about to frame the communication tips I have. Gender is one of the most important determinants of health behavior. Men engage in far fewer health-promoting behaviors and have less healthy lifestyle patterns than women. Men do more of the things that are conclusively linked with a greater risk of disease and premature death. The following statistics apply to those men in the United States. Compared to women, men do not have regular routine health exams, men eat less fiber and more fatty, salty foods, and men are more often overweight. Men use less sunscreen, sleep less and not as well, and do not practice testicular self-exams. Men take greater risks than women do, and these behaviors can lead to poorer health. They tend to drive more dangerously. For example, they are more likely to tailgate and run red lights. They tend to speed more, to drive under the influence of alcohol or drugs, or ride with someone under the influence, and to wear seatbelts less often. And men have more risky lifestyles. They tend to engage in risky sports, work, and travel, to carry weapons more than women do, and to have more physical fights. Men also tend to conceal pain and illness. Suicide provides one example. Throughout the lifespan, suicide rates are 4 to 12 times higher for men than for women. Gay male teens are 2 to 3 times more likely to attempt suicide than their heterosexual peers, and account for 30% of all completed suicides among teens. Men conceal their vulnerability by being less likely than women to confide in close friends, express vulnerability, or disclose their problems to others. Consequently, others are often unaware that men are in pain. Men are less willing than women to seek help that can result in serious delays in treatment. Among one sample of college men, nearly 3 of 4 delayed getting help for sexually transmitted infections from 2 to 6 months after they develop symptoms. Men also perceive themselves to be invulnerable. Most American men believe that their health is excellent or very good and report better health than women, even though they die younger and have higher death rates. Men are also less likely than women to perceive themselves as being at risk for illness or injury. Perceptions of invulnerability are also associated with men's failure to adopt positive health behaviors, such as testicular self-examinations. Detected early, testicular cancer is highly curable. However, about half of the men with this cancer are not diagnosed until it is in an advanced stage, when it's fatal or disabling. For example, biker Lance Armstrong experienced blood while coughing and severe pain before going to see the doctor. Research shows that men are far less knowledgeable than women about health in general. Many men have had relatively little experience with the healthcare system and may lack even basic health information, such as how to make an appointment. In one study, 1 in 5 men had health problems that they needed to discuss, but they did not know whom to discuss them with. Many men also feel reluctant to ask questions. Gender can influence the quality of care that men receive from health professionals in other ways as well. Despite their high health risks, men in general receive less information and fewer, briefer explanations in medical encounters than women receive. So why is effective communication so essential for male patients in particular? Well, the research shows that providers who educate are more likely to help prevent disease than those who perform exams or tests. And the AMA reported that a lack of effective patient-clinician communication is a health hazard for many men. So in regards to both genders, men and women do have different communication styles, both verbally and nonverbally. Let's look at the gender differences as discussed by Dr. Will Courtney, said to be a leading researcher and psychologist in the field of masculinity by the American Psychological Association. So in general, men tend to give information while women collect information. Men talk about things, women talk about people. Men talk about facts and reasons, and women talk about their feelings and their meaning. Men focus on competing and achieving, while women focus on harmony and relating. Men focus on rules and structure, and women focus on fluidity and flexibility. And men tend to be more assertive, while women tend to be more cooperative. Again, these are vast generalizations and do not apply to everyone. So in talking with your male patients, one strategy you might use is to suggest actions rather than instructing them exactly what to do. Questions you might use would be ones like, what do you think you should do first about this? Or how do you think that's going to work? In contrast with female patients, you might want to suggest ideas and talk about feelings. Asking questions such as, what do you feel about the result? Or how do you think that's going to work? Many patients, both men and women, walk in with some level of anxiety. There are all kinds of different expressions of that anxiety. Not uncommonly, a patient will express anxiety by perseverating on statistics. For example, they might insist on facts and numbers from you, such as, how likely is it? Or what percentage of people? Or how can I make sure that? All of these kinds of questions are an expression of anxiety, and it's best not to get caught up in the numbers, but to shift the conversation to address the patient's anxiety. So a question like, what concerns you most about, can help refocus the conversation on the patient rather than on the statistics. A patient may not look at me or answer in a monotone or won't take his hat or sunglasses off. The next patient won't be able to sit still and talks in a rapid, scattered manner that's hard to follow. Both of these patients may feel rather uncomfortable to me, but it helps to remind myself that it's just their anxiety. As you may already know, fear and anxiety greatly restrict one's ability to absorb information. So, doctor visits can be especially fearful and anxiety-provoking for many people. Therefore, communication can be key for patient understanding as well as the healing process. Some of you may wonder whether it matters to patients what gender you are and how that influences communication. A study done by the American College of OBGYNs says that most women don't have a preference for a man or woman practitioner. The one area that they do have a preference is in, not surprisingly, GYN care, where 50 to 70% of women prefer a female practitioner. While not well studied, only 30 to 50% of men prefer a male practitioner for routine male genital exams and tend not to have preferences in gender for the rest of their care. These are the main points I wanted to make about differences in communication between the genders from the research. But what's most important is to relax during the interaction. Neither men nor women really care as much about the provider's gender as we think. They care about being respected and receiving quality care. If you are comfortable and concerned, patients will probably feel comfortable discussing their personal information with you. There are many other factors that obviously influence communication, such as the speaker and the listener's age, culture, language, and other factors. Remember, the more the situation is one of crisis or severe stress, the more likely the listener is to misunderstand. Your communication is filtered through how tired or distracted the patient is, whether they are worried, frightened, or sick, or how much pain they are in, and many other real-world variables. Communication often breaks down when we are not specific enough. As a result, 72% of patients are unable to list medications they take, and 58% of patients are unable to recite their own diagnosis. And healthcare providers can hear things differently too if language isn't specific. At a recent workshop on communication, 35 healthcare providers were asked to quantify the words on the following list. The list shows how the group used words that we hear every day. Sometimes meant 5 to 70% of the time, not too often ranged from 1 to 20%, hardly ever equaled 1 to 10% of the time, frequently corresponded to 35 to 90% of the time, almost always signified 90 to 99% of the time, usually referred to 60 to 99% of the time, often comprised 60 to 95% of the time, and now and then meant 3 to 50% of the time. Before we end, I'd like to also quickly give you some strategies for information gathering which incorporate the communication skills I've just discussed. In most clinical encounters, patients present with an average of 3 complaints. The first complaint is usually not the most significant, so that means that focusing prematurely on the first complaint can waste a lot of time. In the beginning of the interview, we need to be open to hearing the information that patients want us to hear. So what does that mean in practice? To gather the information efficiently, we need to elicit and negotiate an agenda with the patient by seeking the patient's full list of concerns, setting the agenda together, establish limits, and resist the urge to delve in too quickly to the first complaint. Negotiating an agenda could go something like this. We agree that A is important. I also want to address B, and you express concern about C. I'm not certain we can cover all of our concerns. Where should we start? So why bother doing this? Doing this will decrease the "oh, by the way," or the so-called doorknob conversations with patients, when a patient decides to tell you their primary reason for the visit on their way out the door. The reality is that regardless of how they are asked, patients are often not able to complete their opening statement. That's because many physicians, 75% in one study of primary care physicians, interrupt their patients within the first 18 to 23 seconds once they start talking. According to Jerome Groopman, MD, author of the book How Doctors Think, this is because doctors often have a hypothesis in mind, a diagnosis, even before the patient says a word. When patients do speak, there is always the risk that physicians take off on the first concern mentioned, on the assumption that this is the most important reason for the patient being there. You can help patients avoid this by encouraging them to write down their most important concerns so that nothing is left out. And that will save time during each visit and help to organize their thoughts in advance. In very stressful situations, you can encourage patients to bring a friend along to help them remember what was said, and make a list of any problems, a response to treatment, etc., that have occurred since the last visit. So in summary, I hope that these communication tips help you to obtain useful diagnostic information, give patients the sense that they are being listened to, and to build trust and rapport with everyone that you see. Remember, the goal is to enable people to make informed decisions and act on them themselves. Some things you can do as next steps to this training module is to review your electronic medical record system. See if you can combine some of the questions that are asked into 1 or 2 good open-ended questions, rather than asking a series of closed-ended questions. You could also find a coworker and practice some of these skills. It's much better to practice and give feedback to a coworker than to practice on a patient. I'd like to also point out that references for this presentation can be seen on this slide and the next. This concludes our online training session on effectively communicating with patients. Again, this webinar is part of a series of online courses provided by the California Primary Care Association as a demonstration of its mission of strengthening its member clinics and networks through advocacy, education, and services in order to improve the health status of their communities. For more information on CPCA and its services, please visit their website. For other training opportunities, please visit the websites for the California Primary Care Association as well as CARDIA. Thank you for your participation.